Hey everybody, welcome back to our second session of CCA revision for finals. It's really nice to have both Moji and Ziqra back, and we've also got Charlotte back, another Manchester graduate who's come back to help everybody. I've just said back 3 times, to come and help everybody for finals prep and OSCE focused revision. So I'll hand over to Ziqra now. I'll be controlling the slides, but everyone has the option to flick back through them on their own screen, so it doesn't affect anybody else. So yeah, any questions, pop them in the chat. Moji and Charlotte can respond to those there as well. And we'll just be cracking on with gastroenterology this week. So thanks everyone for coming.
So thank you, Charlotte. So thank you everyone for coming. So today's session is going to be on gastroenterology focus, essentially for your CCAs. They have been based on Manchester OSCEs. However, I have made them more broad now that I know that there are other people from other medical schools here, so welcome all. If we move through the slides, I don't know if I control them, can people see that? Sorry.
I think it won't sync to you, but I can just keep doing it as you say.
So if we just move through. So the first thing is a disclaimer. We would like this to be a national series, but it is just a teaching, just for revision purposes, essentially. It's not endorsed by anything. It doesn't replace, obviously, the teaching from your medical school curriculum, and it's just a small resource that we've put together to try and help you guys through your revision, essentially. So today's gastroenterology. Last week, on Monday, we were pushed for time a little bit, so I'm going to be trying to get through so we don't run over. Thank you for the feedback that people have provided. It was very useful. I think people like the interactive element of breakout rooms, so we will keep them. But I have added an A2E examination station as well, just to run through because people wanted a bit of an extra, more difficult stations. And as the sessions run through, we'll be going into more difficult specialties anyway. But this is just the basics of gastroenterology. We'll do some history taking, going through some scenarios and examinations, and then you guys will get to practice like we did last time. We'll give you a bit of a break and then go through some A2E examinations, hopefully some clinical reasoning, some abdominal x-rays that might be common, that'll come up, and some data interpretation as well. Okay. And please put any questions that you have in the chat. I might not see them straight away, but there will be people monitoring it in the background as well. So if we move on to history taking. Okay, so we all know how to take a history, but this is just some basic tips for gastroenterology, like GI focus, essentially. If we just move through, sorry, I keep trying to click on this.
It's okay.
Yeah, so you've got your basics. You've got your presenting complaint, history of presenting complaint. You know how to run through a history. So taking your past medical history, going through family history, social history, drug history. So just GI focus, you can get these conditions, obviously. There are some common ones that tend to come up time and time again. IBD, bowel obstruction. They tend to be common themes in Manchester ones especially. Always ice your patient. We love that. Ask them what they're concerned about, what their expectations are about. Get a summary. Tips wise, always do your Socrates. But for GI especially, ask if there's any change in bowel habits. That probably is sometimes. Get their stool appearance if there is a change. Ask for tenesmus, blood, mucus. If they're giving upper GI symptoms, any nausea, vomiting, describe their vomit. Dysphagia, solids versus liquids, what started first. Do a quick systems review, I would say. You don't need to ask all these questions, just get ahead on things. I go from top to bottom, essentially. Start with headaches, visual symptoms, go for chest, and chest pain, shortness of breath, fever. Just try and cover a broad range of things, see if anything else is picked up in the cues that hasn't been picked up in the history, essentially. So if we move on, thank you. These are just some example stations that I've put together, just with some common presenting complaints for your history taking stations. Obviously, a lot of them are combined stations now, so you'd get your common presenting complaint. You might have to do a quick examination, or they could show you a data interpretation, for example, an x-ray, and ask you to interpret it, or just ask you a few questions at the end. So just have a look through this in your own time, but these are ones that I just thought were common and that could come up, so you could have a quick revise through essentially if you're struggling for time. Okay, so I thought we'd run through one example together, then we'll quickly go through some examination, just GI focus, and then you guys can have a practice just so that we don't run over time like we did last time, unfortunately. So if people can put in the chat what they feel essentially, but we'll run through slowly. So if you've got a 24-year-old female presenting with abdominal cramps and their opening statement or their presenting complaint is, if we click on, sorry, so they've essentially told you that they've had these ongoing tummy cramps for months and it's getting quite frustrating for them. What would be some questions that people would ask? Just pop them in the chat, or you can even unmute yourself if you'd really like to. Yeah, perfect. Socrates a cramp. So if we get a bit of a history of presenting complaints. So abdominal pain. So they've told you it's in the lower abdomen. It's over 4 or 5 months now. Crampy in nature. It's not really radiating anywhere, but it is relieved when they open their bowels, essentially. It's always present, and I believe it was not, yeah, they've not really noticed anything that worsens it or relieves it, essentially. And we put severity in there, and it's 5 out of 10. It's affecting them, but it's not a severe pain. Where would people go from there for their history? What would you suggest? Yeah, good. Quickly check mood type things. Yeah, you could be thinking IBS. Yeah, so if we're going down IBS route, you could check mood. You can see if anything affects them. Let's see what I thought to do when I was making these slides. If we move through. Yeah, so associated symptoms, you can ask a quick systems review just to make sure you've not missed anything. Mood is included in that. Good, any changes to bowels, perfect. So they've had diarrhea, a bit of occasional bloating that they've noticed, again, over the same time period. Good, someone's asked if there's a night theme. What's the significance of the nighttime theme for that person that's just asked? Frequency, it's quite frequent, 6 to 8 times a day. It seems like it is affecting them. Ongoing loose stools. And yes, it was worse at night. Well done for whoever asked that. Good. Yeah, IBD could have nighttime BM. Yeah, it's less likely to be IBS if it's affecting them if it's waking them up in the night, isn't it? Someone's asked for blood. Good. So they have noticed blood and clear mucus, and it's mixed in with their stool. I'm not sure so if we carry on, I would also clarify like the colour of blood as well. Good. Nausea, vomiting. Perfect, guys. So I thought, is anyone else at home with a similar symptoms? They've not had any recent travel, apparently. Systemic wise, they have experienced some weight loss. They're estimating it's about 4 kilos. They're quite tired all the time, and they've had these low-grade fevers. So not too, I would say, if they were actually saying it, I would say they're getting these hot flushes essentially during these flares. If we move on, please. Oh, and they've got some reduced appetite. Thank you. Someone's put one with abdo pain, have to rule out pregnancy. Yeah, that's very, very true. So past medical history wise, they've been told they've got anemia by the GP and it's iron deficiency. So they're on oral iron supplements for that. Family, and they take the occasional paracetamol, probably for the tummy pain as well. Someone's asked about mouth ulcers, which is a very good question for your systemic review. Good. Also wants to quantify the blood. How much? Colour. Perfect. If we carry on, thank you. They're on NSAIDs as well, which is not a very good thing if they're using it consistently and regularly. Family history wise, sorry, not family history. I've forgotten what I've written on these slides. Triggers. So symptoms are sometimes worse during stress. Certain foods exacerbate their symptoms. They've not really clarified what types of food, so that would be something that would be very important to ask and just explore a bit further. Family history wise, they're not giving you like a relevant family history. So What are people's thoughts on differentials, essentially, if you were just given that as a history? Good. So some people have put UC. Good. So if you were asked to give your top 3 differentials for this, what would people say? IBD, IBD, good. A lot of IBDs are coming through. Celiac, yeah? Someone's put IBD, IBS, celiac. Good. I'd accept this. So if we see what I have put as a few differentials, by all means they're not the best differentials, but top differential I would say is IBD. You could even clarify UC over Crohn's, but you can literally just say inflammatory bowel disease if you wanted to. If we see some other potential differentials, if you wanted to mention them, you always have to rule out cancer, don't you? So there was a bit of weight loss. They are known to have anemia. You've not done blood tests to prove that yourself, but they've told you they're known to have anemia, and they've got changes in their stools, in their bowel habit, and they've got blood as well that they've noticed in these stools. IBS is always one. It's a diagnosis of exclusion, remember, so you'd probably have to rule out all red flags, or at least mention it as, we'd have to rule out red flags, rule out this with these investigations, but this is also a differential on your list. So someone mentioned celiac disease, perfect, weight loss. They did mention something about worse with certain types of food, so you could have explored that further as well. There's iron deficiency anemia, there's this, seems like chronic now, it's 4 to 5 months, isn't it, this diarrhea. You could mention some sort of infective colitis. I can't remember if they had any nausea, vomiting. I don't think they did, but you could have mentioned gastroenteritis if they did. It's less likely. There's no travel. It's quite a chronic history, not an acute one. So, and someone mentioned about ruling out pregnancy. If this was just a pure abdominal pain history and it was a woman, then you would have to rule out things like endometriosis and things like that as well. It could be some wider out of the box differential that you're putting down on your list. What would next steps be that people suggest, if that was a question? Good. So if we're going in order, yeah, perfect. Someone's put labs, imaging, and then special tests. And then somebody else has put colonoscopy, biopsy, perfect. Fecal calprotectin, good. Yep, a fit test. Perfect. I think we've got most of them there. Yeah, so do your basics, do your bedside tests first, OBS, examine them, do your initial bloods, get your inflammatory markers, fecal calprotectin. I haven't put fit test in there, but that is very important. And the main thing here, if you're thinking IBD, is to get them in. They need a camera test in, and they need a colonoscopy. You need to take some biopsies, send them off, and see. Yeah, good. TTG, good. Someone said celiac disease before, perfect. Stool cultures to rule out infection, and then you've got your management as well, haven't you? So that was the first run through. We do have 2 scenarios for you guys to practice later on, but I just thought, just for timing reasons, we'll go through the examinations first, since people are quite confident with GI exams anyway, and then we will run through the scenarios in a little while. So examination wise, I feel like GI, cardio-rest, they're all exams that you're taught very early on, so people tend to be more confident on them than the more specialist exams. So if we do a quick run through, so we always start off with the peripheries, don't we? We always do an inspection, an end of the bed examination, an end of the bed inspection of the patient, check their peripheries, and check basically, I always go, remember it as peripheries and then upwards, isn't it? So you check for things like on their hands clubbing, check for signs, leukonychia, check for signs of malnutrition, colonychia, look at their hands, see if there's anything, what was the obvious ones, Dupuytren's contractors, anthermata, and we move on to the wrist, check for anything like palmar erythema with chronic liver disease, feel for the pulse, check for any tremors, which could signify encephalopathy. Scratch marks could signify like IBD users or like raised urea, for example. Then I tend to move up into the eyes, so check for pallor, conjunctival pallor, check for any yellowing of the sclera. Then we always move down into the mouth, don't we? So check the size, check for angular stomatitis, check for any ulcers, for example. And then I always do an inspection of the chest, so check for your usual scars. Make sure you know your scars that are relevant to GI history, but you could also, if you're stuck, just mention any scars that you can see on the chest. And yes, important for GI is just check your supraclavicular nodes. And if you wanted, you could mention gynecomastia, especially if it's a male. And then you've got the things that cause gynecomastia that are listed. Obviously, there's more. These are just some common ones that I've put. So if we move on quickly, thank you. Oh, yeah, spider nevi as well. So I've just put some scars in there just because I didn't put it in the last slides. Obviously, you could just get it from the internet, but just common ones. These are more for cardio, to be honest, cardio rest, but you can see a median stenotomy scar, pacemaker insertion, thoracotomy again. I would say you'd probably have to inspect the abdomen for scars relevant to GI surgeries. But these are your 9 quadrants. Again, we all know this by the time you're getting ready for your 50-year OSCEs, but just make sure you can name them, make sure you're palpating the right regions, and then in your head try and correlate which organs you're palpating for as well, essentially. If we move on, thank you. Thank you. So main thing is, again, start with your inspection. It's always inspection and then palpation, isn't it, first? So main thing is there any abdominal distension? There's your 5 F's, isn't there? Fats, flatus, feces, fetus, and a mass. Check for any veins that are distended, which could signify portal hypertension. Check for hernias, any stomas that are relevant. We start with our light palpation of those 9 areas. We then go into deep. Palpating for the liver, go from right iliac fossa to your right costal margin. Then you always palpate the spleen. Make sure you don't forget the kidneys. I used to always forget kidneys. Go for gallbladder. We've got Murphy's sign. After palpation, we always move on to percussion. Do the same thing, liver, spleen, just include the blood this time. Shifting dullness doesn't tend to be relevant because most of the patients that you have won't have ascites suspected, but it is there. Offer it, didn't you say? If you suspected ascites, I would do a shifting dullness test. Then you auscultate. So it should be low-pitched gurgling sounds, like a rumbling sound, basically, like when you're hungry. If you can't hear anything, listen for 2 minutes. You're not going to get a patient with no bowel sounds in an OSCE station. I highly doubt it, but just say, if you're short for time, just say, oh, I'd listen for 2 minutes, make sure there are sounds if there wasn't any sounds. And then finally, you could auscultate for renal bruise, and auscultate for liver ones as well. So I believe the next one is a focused examination on cholecystitis. So the feedback from last time was you wanted some specifics on focus examination. So if the station scenario was, please take a focused examination for a patient with suspected cholecystitis, what would people be looking out for when they were doing their examination? So thinking about inspection, what signs you'd look out for in palpation, any specific signs for cholecystitis or even similar conditions like cholangitis or biliary colic, for example. Yeah, fever, Murphy's positive, good. Yeah. Yeah, a lot of people are saying Murphy's. Jaundice, itching, good. Right upper quadrant pain, tachycardia. Yeah, so this is just what I thought. By all means, it's not the most focused, but sometimes these conditions that you get don't have a lot of signs and you have to do a whole focus examination and you get confused on what to mention. But there's a lot of things you can still mention, even if it's not that specific to cholecystitis, for example. So if we run through, just your inspection's always the same. So look at the patient, mention how they're sitting and standing. So if they're not lying still, it might not be peritonism. The pain's not worth some movement. Are they jaundiced? It's not really specific for cholecystitis, but do they have a CBD stone stuck somewhere? Is it cholangitis? Is their abdomen distended from where you can see? Do they have scars from previous surgeries? Do they have scratch marks? Someone said temperature tachycardia. So mention all these things. Then Go into palpation. Is there any tenderness? Again, right upper quadrant tenderness. When you're deeply palpating, are they guarding? Is there any signs of rigidity? Again, Murphy sign. Can someone quickly tell me what Murphy sign is and what it indicates? If not, it's fine. So essentially, if your gallbladder is inflamed, yeah, perfect. So pain when removing your hand from right upper quadrant after inhalation. Yeah, a lot of people have put the same thing. So yeah, so if your gallbladder is inflamed essentially, and you take a deep breath in, your diaphragm tends to move down, doesn't it? So then your gallbladder will essentially move against the person's hand when they're palpating, which will cause this reflex. So you get this painful reflex on inspiration essentially. But that is a very specific sign for cholecystitis. Yeah, so keep your finger under the right costal margin, mid-clavicular line, get them to breathe out, then take a deep breath in, and they should have this like inspiratory arrest essentially. Other things that you could mention, it's not really relevant to cholecystitis, but you could have something like, you can mention things like, oh, the gallbladder is not palpable, for example. It's more to do with, it would make more, if a gallbladder was palpable, it makes malignancy more likely than cholecystitis, but it is a gallbladder related thing, so you could mention it. Then we always move on, finish your whole examination, percuss everything that you need to percuss, auscultate. Again, normal bowel sound should be what you hear, but if it's reduced, post-op ileus or any type of ileus, is it peritonitis, for example? And then for any type of condition, I would just always offer the fact that you would do a hydration assessment as well at the end. Have I missed anything in the chat? Just double check. Sorry guys, the chat's not loading for me as quickly as it should. Okay, if we move on, I'll just keep on top of the chat. So the next one that I wanted to quickly run through was focus examination, example of like bowel obstruction, because I know it's a station that especially Manchester likes to use quite commonly. I'm not sure about other schools, but if we quickly run through the same thing, what signs are people looking out for if the station said take a focus examination on bowel obstruction specifically? Perfect, yep. Yeah, a lot of good things are coming in. So some people have mentioned distension, auscultate, tinkling bowel sounds, perfect. Bilious vomiting, reduced bowel sounds, tender abdomen, perfect, guys. So similar thing, always start with the peripheries. Do a quick, I wouldn't do a hydration assessment straight away, but just look at them. Are they dehydrated? Check their observations. Or mention that you will check their observations for things like hypertension. Are they tachycardic? Do they look like, or do they have a temperature? Are they vomiting? Is it bilious? Is it fecal matter? Then always go on to your inspection as normal. Again, perfect. So people have mentioned distension of the abdomen. Again, is the patient lying quite still? Do they have pain on movement? Could it be peritonitic? If you can inspect, look for surgical scars. Remember, adhesions can be a very common cause of bowel obstruction. So you can mention, oh, I don't see any scars, or there are scars, and what scars are you seeing? I would always look for hernias as well, and then see if there's any stomas as well, and just mention what's in the stoma, for example. Where is the stoma? What type of stoma is it, if you're quite confident with that? Go on to palpation after that again. Do all your quadrates, do all your deep palpation of all 9 quadrates, light palpation as well. Check for tenderness. If you're doing a deep palpation, make sure you're mentioning that you're feeling for any masses and things like that. When you're palpating, mention, is there any guarding, any rigidity at the end? Go on to your percussion. If there's a lot of gas in the bowel, it should be like a generalized tympany instead of like a dull sound, essentially, which you could mention in your examination. Go for auscultation. A lot of people have mentioned this already, but if it's early obstruction, you get this high-pitched tinkling sound, don't you? If it's completely absent bowel sounds, then it's either an ileus or it's a late obstruction. One thing is, obviously don't do this unless you have to in the examination, but offer a rectal exam as well. I think it's quite an important part of especially a bowel obstruction examination. Just say you would consider doing a rectal examination. Empty rectum tends to be quite common in obstruction, but fecal impaction, you can see blood or mass, which could signify other conditions, can't you? So, has anyone got any questions on that? Sorry, it was a quick run through. I just wanted you guys to have a bit of time to practice your own scenarios. If not, so the next 2 stations are essentially, you guys, like last week, will be put into breakout rooms if that's possible. We'll send you a script, and if each person in the pair has a go at one of the stations, and we will try and drop in to your breakout room to try and give you some feedback.
Okay, so shall we just pick up where we left off? We'll start with scenario 2.
So just one thing, I think I noticed in the script there was one little mistake about hemoptysis in the 3rd scenario, so sorry about that. I should have got rid of that from last week's slides, which may have confused some people, but let's just run through what it should have been. So scenario 2 was this 67-year-old male or woman with a stomach ache. So essentially it was the fact that they've had this awful stomach ache, bowels haven't been right, history presenting complaint, if you had ascertained all of it was in the lower abdomen, mainly left-sided, gradual onset around 6 to 8 weeks now, bit of cramping, bit of bloating. They've noticed it worst after a meal or meals. 6 out of 10, occasionally opening bowels. If you had asked about associated symptom, they feel quite sick, nauseous, a bit of a reduced appetite. Bowels are now opening every 3 to 4 days, if you would ask specifically. Previously, it was daily, so there's a bit of constipation history there. Their stools are narrower, if you went into a bit more detail, and occasionally they would have noticed some dark red blood mixed in with the stool. No mucus, no feeling of tenesmus. If we moved on to family history, systemic symptoms, if you had did a quick systems review, they would have had unintentional weight loss, a bit of fatigue, but no fevers, no night sweats, anything like that. I think this was meant to be a red herring if anyone actually picks up on it, but associated with a bit of heartburn, but no vomiting, no dysphagia, anything like that. Past medical history, if you would ask, they had diabetes and hypertension. They were only on amlodipine and metformin, bit of ibuprofen for back pain. If you got this far, it was their dad died of bowel problems in his early 70s. I think in the script it specifically says bowel cancer. And then social history-wise, they were an ex-smoker. They drank 10 to 15 units. They live alone. I don't think anyone probably asked about fibre, but if you did, the diet was quite low in fibre. So what were people's thoughts on differentials in their head, or when they communicated next steps, what did people do in their own scenarios? Yeah,
Give us on in the chat.
Perfect. Yeah, colorectal cancer, IBD, diverticulitis. Perfect. That's good. And did anyone get into communicated next steps with their patient, what they would have done? Yeah, perfect. 2-week wait then. Good. So I think the main differential here was, your colorectal malignancy is something you have to rule out. They're over 60, they've had this change in bowel habit and unintentional weight loss. It's ticking all the red flags, isn't it? People have mentioned this already, diverticular disease, left-sided abdo pain, wasn't it? IBD, IBS, colonic stricture. Next steps, so communicating it wise, just mentioned the quick things you would have done. You would have observed them, tried to do an examination, do some bloods, maybe some stool cultures you could have sent off. A fit test would be important in this scenario, but the main thing here would have been a 2-week wait, and you could have explained it as you're going to refer them to a specialist for an urgent camera test, just because of what you're worried about, essentially. So unfortunately, I didn't get to see everybody's 2-week wait just because we weren't able to pop in, or I wasn't anyway. But if we were to communicate the 2-week wait, if we just move on, I think the next slide is 2-week waiting. So this slide was on for last week for respiratory cancers, but essentially it's a similar vibe if we just load up the whole slide. So the way I would explain it is, don't be scared to say the word cancer. Oh, sorry, I put in the referral guidelines. So urgently refer anyone within 2 weeks for age 40 and over with unexplained weight loss and abdominal pain, or age 50 and over with unexplained rectal bleeding, 60 with anemia, change in bowel habit, and unexplained weight. I think the most likely thing you're going to get is an old person, 60 plus, change in bowel habit, unintentional weight loss if you explored further. You would offer a fit test if you think they won't meet the 2-week wait guidelines. But I think for your exams, a 2-week wait is safer than saying a fit test, unless you're definitely sure they're, for example, like a young patient, and you're really not sure. You can say, we will do a fit test, and if needed, 2-week wait. But to be on the safer side, I think 2-week waiting someone won't get you to lose marks, essentially. I've just put something in about 2-week wait for suspected upper GI, just because I don't have a station prepared for it. So if we move on just for that for guidelines, thank you. Just offer an OGD or an urgent OGD for anyone with dysphagia, 55 plus with any weight loss, plus abdo pain, reflux and dyspepsia. I've put pancreatic cancer as well, 40 plus with jaundice, and then if you wanted to assess gallbladder cancer, urgent ultrasound scan with an abdominal mass consistent with it. Same with liver cancer as well. In terms of communicating it, I'm sure everyone did very well, but the main thing is tell them what you're going to do next, set up the scene, get a bit of permission from them. So you can be like, some of the symptoms you mentioned, we do take quite seriously. We'd like to rule out a more sinister cause, such as cancer, for example. I think the thing that you could do is not say the word cancer, which could lose you a lot of marks, essentially. So then you'd go on to explain that you would like to arrange them an urgent referral to be seen by a specialist team. This will most likely involve a camera test of your back passage. And then you can do a quick explanation of what that involves if you wanted to. Main thing is reassure them. It doesn't mean that they have cancer. It just means a lot of people on this pathway can have non-cancerous causes. Explain the other next steps, blood tests, they could potentially have some other scans. And then just in terms of logistics, they'll get a letter or text within 2 weeks, stay in the country, make sure their address and details are up to date, essentially. So, and then always safety net them as well. So please put in the chat if you have any questions. I'll just quickly run through scenario 3, just because I'm running a couple of minutes over schedule already. So this was take a focus history as well and explain next step. This one I've realised is a bit of a more open differentials unless you found that cue that you needed to. So it's someone that's exhausted all the time. It's affecting their life, essentially. In terms of history of presenting complaints, if you explored it further, it was the tiredness for over a year now, gradually coming on. It's been quite bad for the last 3 months, not really relieved by rest, no low mood or sleep disorders. If you went into a bit of a GI symptoms question, so they would have noticed some bloating, worse with certain foods, and that was the big cue if you had got that cue. And if you explored further, it was with like carbohydrate types of food, like bread, for example, pasta. They had occasional abdominal discomfort, but they weren't supposed to describe it as pain. Intermittent loose stools, but there was no blood, no mucus or anything like that. They did have some unintentional weight loss, but not as severe as the other scenario, and it was over like a whole last 6 months, I think. Normal appetite, and I don't think many people got this, but they were supposed to have an itchy rash, which is not really needed in any scenarios. If we move on to past medical history or whatever that I've missed out.
Sorry, it's not moving for me for some reason.
Oh.
It's just my Teams, I think. Let me just do it manually. There we go.
Yeah, perfect. So, past medical history, GPs told them they're anemic before, so they're on oral iron for it, but nothing else crazy. It's quite difficult to get a full history when you have to communicate next steps, but if you did manage to get a family history and a social, they had a sister with type 1 diabetes. They've never smoked, they're minimal drinker, and the main thing is they were telling you it was affecting their work. So if you asked them, you would have figured out that they were a teacher by occupation and it was really affecting their quality of life, essentially. What were people's differentials for this particular scenario? And what next steps did you discuss with your patients? Sorry, someone's put a message that I can't see. Moisey replied to, what would the key safety nettings be? Yeah. Sorry, I didn't see that. So key safety nettings are exactly like we've put, yeah, so severe abdominal pain while you're waiting for it. You've not opened your bowel for a long time, not passed any flatus for a long time. Yeah, 2-week wait then, perfect. Significant bleeding as well. Anyone got any top differentials for this? It was a bit of a broad thing, but I think the main cue was the food. Yeah, perfect. And what were the next steps that people discussed with in their own scenario? Good, everyone's getting similar things. So celiac disease, IBD, IBS, people have put, they've mentioned they've got anemia. Could be anemia from things like, it was a woman, wasn't it? So very heavy, painful periods. Anemia of chronic disease, B12, hypothyroid. You could have explored a quick mental health history as well. Perfect. Next step, TTG, endoscopy, biopsy. Perfect, guys. So again, tell them you're going to do a quick examination. You're going to do some observations on them, get some bloods done. Again, just cover your other differentials as well. So get B12, get your folate, some thyroid functions. But the main thing here is if you think celiac, get your celiac serology. So your TTG antibodies are the main. But the gold standard is, remember, you'll have to refer them for an biopsy of their intestines, won't you? Endoscopic intestinal biopsy. And these are some things that are things to look out. Sorry, we've not got that far. So if we just quickly fold through, yep. So B12 folate TFPs. It's okay. It's okay. My internet's terrible as well. Slagging. Yeah. So gold standard care. Get your intestinal biopsy. Look out for villus atrophy. Obviously, you guys won't be doing that, but just say you'll send them for a biopsy. They need a gluten-free diet, but if they're going for a biopsy, they should have had gluten in the last 6 weeks. So make sure gluten-free for symptom control. When they're going for their biopsy, make sure they reintroduce into their diet, otherwise you won't see anything. You could mention a dietitian referral. It's not a major thing to make or break your scenario. Okay. So, sorry, I feel like I've been talking a mile an hour really quickly. But we are giving you guys a 5-minute break because we didn't give you a break last time. And I think so. I thought to add in the station about A2E examinations. I'm sorry if your uni doesn't particularly examine this. Manchester does, and A2E examinations is always a helpful thing for your ILS and just for F1 in general. So first 2 slides are just a run through of A2E, which I'm sure everyone knows. So we'll just quickly load the slides and go through them quickly, and then we can do a scenario together. So introduce yourself. A2E is your main things, aren't they? It's airway, breathing, circulation, disability, expose the patient. And it goes from most important, what's going to kill the patient first, to a more comprehensive examination. So airway, we know how to do this. If the patient's speaking in full sentences, it's completely patent. Is there any added sound? So I've not added all the added sounds, but I've just put in snoring question mark, which isn't very helpful. But if there's any, if you're not sure if the airway's patent, just do a head tilt chin lift. Put in an airway adjunct if it's helped, and then escalate as well to your seniors. Go on to breathing after that. Do your end of the bed examination, check for cyanosis, do your respirate, oxygen sats, check if the trachea is central, go in for chest expansion, percuss, and then auscultate as well. If we just load the next parts, thank you. Yeah, and then in breathing, consider for like investigation, chest x-ray, ABGs are the main thing. Put them on high flow oxygen if their sats are low. Sputum culture you could do. I don't think it's an urgent thing that you have to send there and then in an emergency situation. And then, yeah, so just running through again quickly. Circulation includes your pulse, BP, check your temperature peripherally because you'll check a formal temperature in Disability, check for cap refill, look at the JVP, auscultate your heart sounds, do a quick fluid balance. I think that's a bit that people forget. Is there any edema? Check the mucous membranes. But in this, if there's any problems, get 2 wide bore cannulas in them, fluid resus them, measure their urine output, send off some bloods. If it's sepsis, IV antibiotics, anything to do with the heart, get an ECG. Disability wise, are their pupils equal and reactive to light? Check their BMs, very, very important. Check sugar levels, check temperature, and check their GCS as well. It's more difficult for disability, but maybe things like if BM's low, hypoglycemia protocol, might need a CT head to rule out a stroke, for example, probably need to initiate sepsis 6 if there's any signs, and then expose. Even if you can't expose in the station, just say you'd inspect for rashes, bleeding, bruising, check their calves. Is it soft, non-tender? Check the abdomen. Again, soft, non-tender. So I think I've got 2 quick scenarios to run through, and I'll just ask you guys to put in the chat what you think we'd have to do at each, after A, B, C, and D, obviously. So the first one is, I actually can't remember. So scenario 1. So review a patient who was presented to ED after a large episode of coffee ground vomit. So airway wise, so you're checking if it's patent, aren't you? So it's patent, they're speaking in full sentences, but they've obviously vomited. So you could mention there's a risk of aspiration. So into breathing. So if we get, we'll just load up everything. I think people know how to take a B, but, oh, not circulation, sorry. It's fine. So end of bed wise. So they're looking quite pale, drowsy. You have checked peripherally for cyanosis. The nurse has told you, whoever's in there has told you the respirate is 26. Their oxygen sats are 94%. If you do a chest expansion, symmetrical, percussion's resonant, clear breath sounds. Would anyone do any investigations or add anything at this point? Yeah, could do. So it's not, stats are not too low, but if you're worried, 15 litres non-rebreathe oxygen is always a safe choice. But B seems to be okay at the moment, isn't it? So if we move on to C, but the respirate is quite high, yeah. So circulation-wise, pulse is 124, BP's on the low side, 81/46. Temperature, they've got cool peripheries, cap refills prolonged, JVP's not raised, normal heart sound, there's no pitting edema, mucous membranes are dry. What would people do after this? Yep, fluid resus. What do you need to put in for a fluid resus? Yep, good. Get 2 wide bore cannulas in. Perfect. So I think I've done it so that, oh, and they've got reduced urine output as well. So in terms of B, consider 15 litres non-rebreathe. Could get an ABG. Might not be needed for this scenario, but as you know, you probably would actually. BP is quite low. Oxygen sats 94%. You don't know what's going on with them. Get an ABG, get a VBG. 2 large bore cannulas, which people have mentioned. If you fail IV access twice, I think they recommend go IO. Send some urgent bloods if you're putting in a cannula. Get clotting, get your group and save. You could cross match if you're in anticipation of anything. And then fluid resus, 500 mils. Always mention what fluids you're going to give them. Safe bet is sodium chloride 0.9%. I would say quicker than 15 minutes, maybe over 10 minutes, and then escalate very early on in your scenario. If we move on then, so you always have to recheck, but you'd have to move on as well after you do one investigation. So your ABG results are back, which is quite quick. What are people worried about with this ABG, or what would they do when they see this ABG? Okay, someone said sepsis 6. Why sepsis 6? What are you particularly worried about? Yeah, good. Raised lactate. Metabolic acidosis, raised lactate, low HB. Someone's put could be due to hemorrhage. Good. So yeah, so remember the presenting complaint or the scenario was that they had a large coffee ground vomit, didn't they? So perfect. You do have a raised lactate, could initiate sepsis 6. You won't be wrong there. But you probably have to think about the fact that they're bleeding. The HB is very, very low. So if we continue, I'm not sure what's going to load next. I think when I converted this to Google Slides, yeah, so the whole examination loads. the answers have loaded as well. So disability, so GCS is 14 out of 15, confused. If you expose them, temperature was 36.2. They've got no rashes. They've got a bit of epigastric tenderness, but their calves are soft, non-tender. What would you do in terms of management here? Could do a Blatchford score. In terms of immediate management, what would you do? Good. With HB so low, you'd order a blood transfusion. Yeah, I agree. So the main thing here is, what are you worried about? I think we've loaded the answers up, but what's the main thing that you're concerned of? What's going on with this patient, or what do you think is going on with this patient? Yeah, an upper GI bleed. So if we flick through, thank you, Charlotte. Main thing is they've got an upper GI hemorrhage, don't they, with ongoing hemodynamic compromise. So they've got this epigastric tenderness. You could mention that it's most likely due to peptic ulcer disease. If we load the next part, which was supposed to load first, I think it's just me putting the animations in wrong. But yeah, so after those ABG results, I would have activated the major hemorrhage protocol and escalated very immediately. Blood transfusion is the right thing. If you'd said escalate, we need a blood transfusion immediately, fine. But just because of how low the HB is, lactate is very raised, just go for an activation of the major hemorrhage protocol. Once they're stabilized, the definitive management that you're going to need is an OGD. You're going to need IV PPI infusion. You need gastroenterology to be involved. You need surgical teams to be involved if they're actively bleeding from somewhere. Is that okay? That was a quick run through. But well done, guys. So scenario 2 is scenario 2 is assess a patient with abdominal pain. So we'll do the same thing. We'll just see airway. So airway's patent again, speaking in full sentences. So airway's safe. We don't need to do anything. B. So B, again, you assess the same things. Always mention the same things. Always do the same things so that you have a plan in your head. They look hot, sweaty and flushed, apparently. Quite cyanosed. Rest rate is high, 28. Oxygen sats are low, 90% on room air. Trachea central, though. Chest expansions equal. Normal percussion, normal auscultation. Anything people would do at this point in the examination? Perfect, good. 15 litres non-rebreathe, get an ABG. Anything else people would get with sats so low? Anything they would order? Yeah, perfect. Chest x-ray, guys. So next bit. Yeah, so everything that you guys have said is mentioned here. High flow oxygen, 15 litres or a non-rebreather, get an ABG, get your portable chest x-ray if they're unwell. So your portable chest x-ray is back. Any concerns with this? It's very quick chest x-ray. And I think the next one is your nurse telling you that your ABG results are back as well, so you can analyse both at the same time. Anyone concerned or anything that you would do when we move on to C? Before we move on to C? If not, we can move on. So lactate's quite high, isn't it? Yeah, IV antibiotics. Maybe if you're thinking IV antibiotics, you mentioned this before, Joseph. What could you potentially think about initiating? Yeah, sepsis 6. Good. So I would say chest x-ray is relatively normal. We don't have something to compare to. I did want to get a really funky one, but it's a portable chest x-ray. It's not the best exposed, but it looks okay. ABG results are concerning though. Lactate 5.6, they're acidotic, but their O2 is normal, but remember they're on 15 litres non-rebreathe as well. So if we move on to circulation, let's see what the rest are. So if we do a full examination, pulse is 122, again, blood pressure is on the low side, cap refills prolonged, fluid balance is fine. They do have a reduced urine output. Anything people would do here? Same thing, blood pressure is quite low, isn't it? Get your cannulas in, fluid resource perfect. Disability-wise, Also, escalate early. A2E examinations love to escalate early. You need to escalate to a senior as soon as possible. Disability. I believe the pupils are, I can't remember this scenario. Sorry, Charlotte. If we flick through just the rest of it until the, yeah, perfect. Good. So pupils, fine. BM's fine. Temperatures on the high side. Inspect the full body. Calves are soft, non-tender. They have a bit of right upper quadrant tenderness. You've noticed their jaundice all of a sudden. And no rashes. What's people's thoughts on what's going on? What would they initiate? What would they do? Cholecystitis, okay. No corrected yourself, no cholangitis. Why cholangitis and not cholecystitis? Good, so Joseph has put cholangitis, patient's got jaundice. Anything people would initiate or do after C, D, and E? Just quickly.
We've got some people typing.
Ooh. Sepsis 6, secondary to cholecystitis, Usman has put. Perfect. So we've got a few cholecystitis, a few cholangitis. Ring reg, yeah. Escalate early, good. Would you do anything before you ring the reg, or as you're ringing the reg? What management would you say you're going to start or would like to start? So just for timing's sake, should we just load up the rest of it so people can have a look? Thank you. Yep, so everyone's mentioned this already. Patient's got fever, jaundice, right upper quadrant pain. They've got the triad. So it's concerning for septic shock, possibly. Their blood pressure was on the low side, lactate was raised, likely secondary to ascending cholangitis. They've got right upper quadrant tenderness, jaundice, they've got the temperature. Management-wise, definitively, you're going to need these, but in the meantime, what I would do is, yes, after C, which was supposed to load way before, is get your cannulas in, send off your bloods, fluid resus them, you need to initiate sepsis 6, or you need to mention you're going to initiate sepsis 6 in the scenario. So send off blood cultures. You've done your ABG for the lactate. Urine output was low, so you'd either mention you're going to monitor it or just mention you would consider catheterizing the patient to monitor it. You've given them oxygen, you've given them IV fluid, so the only thing left is give them a broad spec antibiotic according to your trust guidelines, and you can't go wrong. Is that okay, guys? So in the next 7 minutes, we'll do some spot diagnoses of data interpretation so that you can have some time to do the last 2 communication stations that I've prepared for you. So I think the first bit is abdominal x-rays, because it's not one that's often taught as much as chest x-rays. So in terms of abdominal x-rays, I think the main thing is figure out what you're looking at. Is it AP supine, AP erect? Is it a good exposure? The way I look at it is look at the bowels first. The main thing usually for GI is the bowels. Then if you've got time and it's a good exposure, look at the bones, look for any artifacts, stones, calcifications. In terms of bowels, small bowel, large bowel. So the small bowel tends to be in the middle and your large bowel tends to frame the small bowel. The main difference is your large bowel has like little pouches, hostra, and they don't go, you can't see my mouse, but they don't go across the bowel completely. Whereas small bowel, yeah, perfect, got a pointer. Small bowel, which is not very obvious in this one, is more central, but you've got the valvulate, yep, there we go, connivences, which will traverse the whole bowel, whole length of it essentially. And then the main thing is make sure you know your upper limit. It's 3, 6, 9, isn't it? So small bowel, the upper limit for it should be 3 centimeters. Colon, 6 centimeters, but your cecum has an extra bit of width to it. It can be up to 9 centimeters. So if you're looking for bowel obstruction or anything enlarged, your limits are 3, 6, and 9, which is a good set of numbers to remember. Then look at your bones if you have time. Make sure you're orientated with a abdominal x-ray. You can see your spinous processes, you can see your bowels, you know where your sacroiliac joints are, you know where your femur is if it's a good x-ray. So I've got 3 x-rays. If people can spot diagnose them, we will move on and just quickly run through them. What do you think about this one? The pointer's pointing at something very important. Joe has put LBO. Okay. Why LBO and not small bowel obstruction? What are you seeing? Obvious, big colon. Yeah, we've got a few answers. If we load the, yeah, good. Pointer was pointing at something very important. You've got, if you wanted to mention, most striking abnormality, you've got massive large bowels dilated, haven't you? Way over the upper limit of 6 centimeters. Main thing is, ulcer is visible. It's not traversing the whole large bowel, the bowel, so that's why it's not small bowel. If you can't see any small bowel dilatation, your ileocecal valve is probably competent. And I think the rest of this explanation runs through, yeah, no evidence of perforation, no abnormalities. Your differentials at this point would be some sort of obstruction, so it could be mechanical, or it could be functional bowel obstruction. And if it was mechanical, you could run through the causes of mechanical bowel obstruction, essentially. Please, could you point out the host? So, yeah, pointers there. So can you see the line is not going across the whole bowel, essentially. It's quite thick as well. I think the next one might be, yeah. I think you'll understand it better if you see the next scenario or if you see the normal X-ray. Oh, it's not very zoomed in, is it?
Yeah, I'll try the next one.
Yeah. So, next one, spot diagnosis wise. I think this one might make it make more sense. So just, if you can, point out the most striking abnormality, essentially. Yeah, we've got small bowel obstruction as an answer. Good. Should we load the answers up? Oh, somebody else is typing. Okay. There's a bit of a trick one, guys, sorry. It's actually normal bowel gas pattern. Unfortunately, there's no actual obstruction in this one. But you are right, you can see that your valvulae conventans here across in the centre. But it does look like there's something wrong with it, I do agree. But it's completely fine. I think it's just people, we don't look at abdominal x-rays quite often, do we? But there's no obvious abnormalities anywhere. There's not meant to be any major skeletal differences. It's just normal gas pattern. There's no evidence of perforation. There's no mucosal edema either in this particular example. And then there is one more spot diagnosis. This one's a little bit funky. Yeah, just the pointer's pointing in very good directions. Any takers for this one? Oh, someone's put in big capital letters, megacolon. Any other takes on this one? Yeah, should we load up the answers? Could be coffee bean, yeah. So the big thing here is, so it's a bit of a difficult x-ray to read actually, but you do have, so this would be dilated small bowel instead. So you can see the lines are traversing the whole bowel. Your large bowel is difficult to see. So you've got a bunch of small bowel in the middle. The main thing here is, so you can see a ligament that's running down. That's not usually visible. So when it is visible, there is evidence that there is free intra-abdominal gas. And also, this is more difficult to see, essentially. In the corner, the liver edge is a lot more lucent than it is normally. So that is also a sign. But I think the fact that you can see the falciform ligament is more of a bigger sign for people to see. So it's suggestive of free intra-abdominal gas. Yeah, looks too. Perfect. So if you've got free gas in the abdomen, what does that mean?
We've got someone asking what you mean by looser edge.
Did I say looser edge?
I think more lucent, you said.
Oh,
but,
lucent, sorry.
For the liver.
Oh, sorry. It's just for the liver, so it just seems more, it just seems whiter, doesn't it? If you can, yeah, so in the pointer,
Is
so
that
you can
it?
see the ligaments, just a bit towards the top there.
This one?
Yeah, so where the liver, yeah, perfect. That's your ligament there. So that's a lot. You can actually see the ligament as a complete white out structure there. And the liver up in the right upper quadrant, yeah, is a bit more visible as well. But I think it's more obvious to see the actual ligament. So when I mean lucent, sorry, I didn't say looser. It just means that it's like a whiteout image, which is indicative of air in the abdomen, essentially. So there could be a perforation somewhere. Good. So I think that's it for spot diagnosis, unless I have one more quick scenario. Oh, fine. This is a quick one. If we just load all of it up. So in this scenario, I'll give you guys a minute to read it. Oh.
Sorry.
It's all right. So this is a clinical background of a man. If you were asked to read this and interpret and escalate to a senior, what are you worried about? And how would you escalate to the senior, and what would you say, essentially, would be the question. So just have a quick read of this and tell me what you're worried about, essentially. So I think the key things here, excuse me, patient's day 3 post-laparotomy. They had a perforated diverticulitis. They've commenced with bilious fluid vomiting today. They've not opened their bowels for a while. When you examine them, they've got this distended abdomen, no guarding, no peritonism, and you've got your lab results as well. Okay, people are putting ileus, bowel obstruction, post-op ileus. Good. In the lab results, is there anything significant that anyone can see? Yeah, hyperkalemia, perfect, good. CRPs tend to be raised anyway. They are post-lab, but it's raised, and the main thing there is the hyperkalemia. So if we move on, so escalating to, so next step is just the usual. Repeat your observations, daily bloods. You need an abdominal X-ray. You might consider CT-AP if there's any concerns for a leak. Management-wise, sorry guys, I'm running through this just because of time. So keep them nil by mouth. You need an NG2. IV fluids. We've got some hyperkalemia there, so you're going to have to correct that as well. Review the analgesia if they're in pain. And your differentials, which a lot of you have mentioned, well done, is post-op ileus, mechanical bowel obstruction you could mention, secondary to any of those. Could be medication induced. They've been on Oromorph, haven't they? Less likely, but could have induced an ileus. Could be constipation. And metabolic causes as well. The clue there was hyperkalemia. Unlikely because there's no infective signs, but post-op infection, mesenteric ischemia is a big one as well. And then this scenario, if that was this was a past station, not the exact scenario, but the next steps would have been S-barring to a senior who would have asked for your management and your differentials, essentially. So S-bar wise, I think a lot of us know S-bars is just practicing getting it down. So mention your situation, mention what's going on. If we just load all of it up so we can see. So it's not the best example, but you've got a 58-year-old man. He's mentioned the important things. He's day 3 post-laparotomy. He's got new vomiting. He's got new abdominal distension. Tell me his background, what's going on. Assessment-wise, you've assessed his observations, he's stable. You've examined him. Tell me what the bloods see, and then you tell me the recommendations. Maybe you want the senior to come review them. But make sure you tell the senior what your management plan is. So you're going to do nil by mouth, NG tube, correct his hyperkalemia, ask what you would consider, and then ask them, is there anything else you'd like me to add? Anything you change in my plan? Please, can you come review him when you have time, essentially. Is that okay? So I'll keep an eye on the chat. But the next two is, I just want to give you guys enough time to practice, is just some communication skills, essentially. So I have two conditions for you guys to go through again. I think it's explaining a condition and maybe a drug. I just can't remember, but just quick tips. Very similar slide from if anyone was here for last week. But get a baseline understanding of any condition that the patient has. Follow a structure. If it's a drug, what is a drug for? How it works, side effects. Always safety net is the important thing. If it's conditions, take a brief history, what they came in with, get their understanding. You then explain the condition. Get the causes in, risk factors, symptoms, talk about future investigations if it's relevant, and then red flag them all the time. Chunk and check them, summarize, use analogies, get a diagram in there as well. So I think common stations that I thought could come up for GI specific, obviously there's loads, but explaining condition wise, it could be so things like diverticulitis. If we load up everything, thank you. So yeah, we've gone through a few today. So post-bilious peptic ulcer disease, GORD, IBD tends to be common stations, just has a lot of things in them. Explaining 2 weight's good. Explaining a PPI is the only thing I could think of for drugs, but I'm sure there's lots and lots of drugs in there. You've got lots of your IBD drugs, haven't you, as well? Diverticular disease is a good one, especially in Manchester, they like to ask that in 3rd year. IBS would be a difficult one, so make sure you know how to explain IBS to a patient as well. And then in terms of difficult communication, there's always this patient wanting to self-discharge when they've been admitted for some sort of monitoring or some sort of high-risk patient, for example, and they want to go. So you've got to explain to them why you want to keep them in hospital, the dangers of self-discharging, assess their capacity. At the end, if you've mentioned everything, and if there is a potential risk of dying, don't be afraid to mention the fact that they could die as well. They could always leave if they wanted to, if they have capacity. So I think the next is, is there more? Oh yeah. This I've already mentioned, but it's literally just how you explain drugs and conditions, check their understanding, explain clearly, get the purposes, get the benefits, side effects of drugs. You always have the BNF, so don't worry about side effects, but check their adherence, ice the patient always, okay? So like last session, if anyone was here, we've got 2 scenarios again. So I think everyone has done well, or well, the histories that I've heard have been very, very good. So we'll quickly just run through. We are 4 minutes till 8 o'clock, so I think we're doing good for time. So first question was, explain biliary colic, give the management, essentially. So key ideas was, mention gallstones. It's a stone, you can mention a bit about bile, actually. If you wanted to give them a bit of anatomy, mention where the gallbladder is, the liver. Say it produces bile, helps digest your fat, so it's usually after fatty meals. And then you can mention things like, oh, some people have tendency to make stones, it could be due to high cholesterol. If this stone is temporarily blocking your bile duct, which is like the tube that's carrying it from the gallbladder to the rest of the body, you can get these symptoms, and that's why you get this on and off symptoms if you're taking a quick history from them. Other things that you would have mentioned, if we'll just load everything up. Yeah, so symptoms, you would have taken a history anyway, so you could have just linked it back to their history. So, oh, you mentioned you get this crampy pain after meals, especially. Maybe it was fatty meals, and then say those are the main symptoms. Investigation-wise, ultrasound scan, look for gallstones in the first bit if that's not already been done. Blood test, check out their liver function, see any infections. Management-wise, you can mention pain relief, okay? The big thing for this station would have been give some good lifestyle advice. So avoid large fatty meals, stay hydrated, avoid dehydration. You could mention a bit of weight loss, exercise, general advice. Definitively, it would have been very good to mention a cholecystectomy. That's the only way you're going to actually get rid of this condition, aren't you? Red flag wise, always red flag people. It's the best thing to do for any condition. Fever, chills, you notice some jaundice, severe unrelenting pain that's completely different to the gallstone pain, which is on and off, tell them to go to a hospital. Next one was explaining GORD and a PPI, wasn't it? So I think the main thing here was the patient had chest pain. So I did a bit of axing on like, oh, I'm a bit worried about chest pain, about heart. Why do you think it's this? But if they're making it difficult, just try and say that we've ruled out heart. It's most likely this is what we've been told. But a good explanation is key. You can mention things like acid is flowing from the stomach back into the food pipe, it's irritating it, it's causing these symptoms, and again, link it back to their symptoms that they've mentioned in their history. A bit of acid reflux, heartburn, sometimes a bit of a sore throat. Risk factors would be eating large meals, fatty meals, lying down quickly after eating. Again, just typical risk factors: obesity, smoking, alcohol. Investigations could be a later down thing if it's needed. So symptoms persist, not worked after PPI, you could mention further investigations like a camera test, OGD. Main thing here is also lifestyle factors. It's like a lifestyle counselling station, isn't it, a little bit? So eating smaller frequent meals, avoiding trigger foods, avoiding lying down. And the whole scenario was they've been given a PPI, haven't they? So mention what the PPI is there for. For in this scenario, it's there to reduce the amount of acid so that it helps with the symptoms, isn't it? If they had, it also protects the stomach lining. So if sometimes you could mention, oh, some people give it you if you're taking medications like ibuprofen. If you've got ulcers, it will help heal the ulcers. Taking it wise, once a day, could be twice a day, depends on what the indication is, isn't it? But you can mention, take it as prescribed if you don't know how they've been prescribed it. Before a main meal, preferably in the morning if it's once a day. How long to take it for, you can check the BNF, you can check the indication. If it's not mentioned in the station, you might not have to mention it, but they've said it's for GORD, so it's usually for a month, isn't it? Side effects, again, common ones, common GI ones are always the same: diarrhea, a bit of stomach pain, but you will have the BNF in front of you. If in doubt, just have it opened up while you're talking about the condition so that you, when you get to the PPI, you can easily explain it. Long-term side effects to look out for, you should mention some rare ones just in case, but can reduce absorption of calcium, magnesium, vitamin B12, but people don't tend to be on it for a long time is something you can mention, but if they have to be, it'll have to be something monitored. And then again, safety net the patient. So if their symptoms with the PPI are not controlled after 4 weeks, they should go back to the GP, have a full review again. They may need further investigation, for example, to investigate anything further if their symptoms have not been controlled. So that takes us nicely to 8:01. So I don't think we've overrun today, which is a good thing. I've just added a bit on major hemorrhage protocol. It's a bit blurry image. Hopefully it's not as blurry when you guys get the slide. It was just for the A2E station where we activated it. So you could just have a quick look through that. But thank you so much for being interactive today, guys. Thank you for participating. Please fill out the feedback forms. I think if you put your email in the feedback form, you'll get access to the slides as well, I believe. And thank you for facilitators for helping out with the stations as well.